today to be able to talk about some of the really interesting work that you've been doing around the impact of COVID-19 on communities, and also I think some of the answers that might lie in yoga to managing distress.
So actually Scott asked me to present this based on a paper that we wrote very recently. So the presentation is mainly from the paper that was published a few weeks ago. I don't claim to be a particular expert in COVID related matters or the mental health particularly. What we tried to do in the paper was to capture in a qualitative way the early period. So somewhere from the when COVID started 2019 and the first year. So we are trying to present a description from a qualitative point of view, from a perspective of, we might call them frontline healthcare workers. And we were, actually all of us started from the University of Jaffna medical faculty, but have now been dispersed all over the world. Australia, UK, and back in Jaffna also Sri Lanka. So we try to, in a way, bring out the picture that we found at that time. We mainly, as practitioners, we had to answer to our patients who were coming for treatment. Some were working in an acute COVID ward dedicated to COVID management, respiratory physicians and so on, and some were GPs and some were community physicians. So when people asked us, patients and their families, we had to be able to answer. So it's something new in a way. We have not faced such a type of situation. Of course, we have had disasters, and that is our background, both natural and man-made war situation and the tsunami. And in a way, this is we can look at it like a disaster. It's not clear whether it was a natural disaster or a man-made disaster, but maybe a little bit of both. So from a perspective of frontline healthcare workers, trying to understand what was happening as this thing suddenly mushroomed in front of us. So I'm talking about this paper that I put here, the one that was published, and it might be worth referring to it. I like to acknowledge my co-authors who produced most of the material, particularly the principal author, Rajesh Kannan, Dr. Rajesh Kannan. He's a GP now, but from a community medicine or public health background. So we had to answer this and we had to give them some reassurance. We had to explain what's happening, maybe sometimes even explain in a medical psychoeducation, you might say, some counseling. And but first we had to understand what was going on. So principally we sort of trawled the social media, looked at the messages and what people were experiencing based on what was happening through the social media, then looked at the literature, discussed among ourselves, colleagues. And so this paper is sort of trying to capture that moment, that early phase. And in a way, it's a historical document in that way of how the pandemic evolved and how it affected different the health sector, and also finally it was affecting everybody. I made a presentation of this before, about 2 years ago, for a Royal College of General Practitioners. So I like to acknowledge that also, but I have updated it and made it a little more current. Now, as I was saying, it was something that started a very small way in China, Wuhan province, but suddenly it mushroomed to affect the whole world. And by March, I believe, 2020, I think WHO was declaring it a pandemic. And this is a picture of how it affected the world. It's taken from the John Hopkins website, where they were trying to keep tabs on what was happening, showing the number of. So this is a final thing that in 2023, October 2023, they stopped collecting all the data, but it shows the number of cases, 600 million, and the total deaths, and the ones, the people who recovered. This is a different website that I got the recovery rate from. So you can see how it affected the whole world. A small viral particle, which some people, there is even contested whether it's alive or not alive. And it brought the whole world to almost its knees. And it posed severe challenges. At some point, some people were quite pessimistic. But somehow people got together and met the challenge, and that's one of the positive, how different people can get together and bring all the resources together, particularly the technology of producing vaccines, and also a lot of innovations in public health control, contact tracing, and the various lockdowns, regional, whole countries. And somehow now, yeah, it's behind us in a way, although their threats are still there and the virus keeps evolving. Recently, they were discussing about a new variant, JN1, that has taken the whole thing up to a different level, I understand. Again, I don't claim to be a particular big expert on COVID and the viral aspects of it, but still we try to understand to some extent. So this is the picture, the world picture, about 96% recovered. Very small percentage actually died, but still for all that 1%, because this varies from different parts of the world. And in the recovery, I think they have also counted people who continue to have some symptoms. So they may not be fully recovered. They may continue to have what's now being called long COVID. So we'll come to that later on. Some of these statistics may not be fully reliable. So it depends on what's being reported. And for example, in Australia, they mentioned that fatality rate was maybe 1% or 0.1%, while in according to the website now, quite instructive. They said in North Korea it was 600%. So that's not possible. Possibly, what I could understand was that maybe North Korea was reporting the people who had died and not the people who had got the cases. So there must be a computer program that works this out, some kind of logarithms and so on. So, but anyway, I just want to give a picture of what happened. Now, for this presentation, I'd like to use our very common psychiatric framework, just as a framework to try and understand the phenomena, biopsychosocial. Always there seems to be a biological background, and even our psychiatric disorders, we try to understand it from a biological point of view. But very important in psychiatry and mental health is other dimensions, psychological and social. So mainly this will be looking at this dimension, but just for completion, and also it helps to present gives a framework. So just quickly looking at that aspect, the brain, the biology, it's not very clear, but it doesn't appear that the virus actually got access into the brain itself, the brain cells. It seems to have affected the brain directly, but through the it seems to have breached the blood-brain barrier, BBB, as it's called. It's a kind of a system that functions to keep unwanted toxins and bacteria and virus and all these things outside the brain, trying to protect the brain. But the virus may have reached through various mechanisms. The one that was quite talked about was the cytokine storm. So it's a kind of an immunological reaction that may be released by what happens in the capillaries, the endothelial lining, the cells there may have been affected, and it may have caused quite a lot of release of various chemicals affecting the neurotransmitter systems and so on. So what they have tried to, what we like to point out more from our point of view, of course there are many other aspects, the respiratory aspect is the main one, but even from a brain point of view, what we might call the neuropsychiatric symptoms. So some are very clearly neural effects like anosmia and some cognitive impairment, sometimes called brain fog, that shows that the brain directly difficulties in concentration, memory, and so on. But some clear psychiatric symptoms like anxiety, various aspects of anxiety, panic, phobias, even adjustment disorders, depression. There were reports of, so this kind of report was from the Journal of American Medical Association, so quite in a way reliable, or it's early research. So from a psychiatric point of view, what seemed to be, what they reported were depressions, anhedonia, loss of motivation, no interest in life, and even suicidal behavior. Some psychotic behavior reactions were seen, and very important for from a current point of view is what we call the post-COVID neuropsychiatric symptoms, and long COVID is part of it. And different reports are saying it may be from 20, and even some have said even up to 50%, staggering 50% may develop what we may call lingering symptoms. I'll come back to this later on, but just to show the importance of the biology. So this may be similar, the symptoms may be very similar to what's is called chronic fatigue syndrome, CFS, or ME, myalgic encephalomyelitis. So it may be some kind of encephalitic process, I don't know, but they have not shown any direct viral involvement. And even long COVID, the exact pathophysiology is still not clearly established, but quite a big percentage. Even last week, or I think 2 weeks, last week, I understand 600 doctors in the National Health Service in UK are suing the National Health Service for having been exposed, they all developed COVID while they were working, because UK was really overwhelmed with COVID infections at one stage, and many of these doctors really worked quite hard. That's another point that I like to come back later on. The vulnerable groups are these healthcare workers who are working on the front line. So they have sued them because they were not provided adequate protection. The PPP, the personal protection that people are supposed to have, masks and those days that was quite common. Nowadays we rarely see it, but so they had to work under conditions that were there was some shortages there. So they were exposed to COVID, and they are now suffering from long COVID and not able to get back to work and so on. So this problem continues there, and some of these symptoms are psychological, affecting mood and anxiety and so on. We can come back to this, but again, I'm not a particular expert here. So mental health consequences. Just for an overview, and then I'll just go into some of these things in more detail as we go along. Scott, please keep a close watch on the time. We'll try to keep a discussion going afterwards.
Will do, Dave. We're about 26 minutes in. We had a delayed start.
Okay. So quickly, the predominant aspect is normal response. Now, this was a really unprecedented, and people have not experienced this kind of situation. Of course, maybe a century ago, the so-called Spanish flu and so on. But people who are alive now, most of them have not seen such things. So there were the normal distress, worry, apprehensions, frustrations, particularly due to the lockdowns and various travel restrictions. Families were separated, people had to stay at home, and so that kind of, and particularly the elderly and children were badly affected by these kind of procedures. And so there is some complaints about some of these measures, and maybe there can be some improvement. So there are a lot of lessons we can learn from this experience in a way that we can improve if in case something like this happens in the future, but also across the board in doing other public health work, community work, in the basic principles of psychiatric care. A lot of things can be learned from what happened. So abnormal consequences, which psychiatry we are sort of we are blamed to be looking at the abnormal, but anyway, certain pre-existing mental health conditions seem to get worse. One is people were, of course, under lockdown and various travel restrictions. They could not access their normal care. They could not attend the clinics or attend to go and see the physicians, or if they were receiving psychotherapy and so on. So many of them had exacerbation of their pre-existing conditions, and also because of the situation of the fear of the unknown and seeing people getting, there are people who saw their family members and then there were deaths, and there were, so many things were happening, and these people who were vulnerable, who had pre-existing conditions, there was a increase. Also certain conditions like obsessive compulsive disorder, we could see even with people who had depression, they were showing OCD symptoms. Then new mental health disorders, people who had never had psychiatric disorders also seem to have developed a new anxiety, depression, and various alcohol and drug related problems, which I'll come back to again. But due to the pandemic, there was a change in the drug and alcohol, the substance abuse picture. Again, that's very important lessons from that. Certain vulnerable groups, again, we'll come back to that. I already mentioned. There are a lot of deaths of people, bereavement, losses, and people had to deal with that. And those who survived, particularly those who had to go into acute respiratory care units and who are on ventilators and who saw other people dying in front of them, they developed PTSD. Now, this long COVID I have already mentioned, but it seems to be quite a big issue now. And how to rehabilitate, how to bring people back into their previous level of functioning. The gradual rehabilitation principles may be very important, and similar approach that we use with chronic fatigue syndrome and myalgic encephalomyelitis, but it may have associated psychiatric conditions, so we may need to treat those also. Frontline key workers were badly affected, again another vulnerable group. Then this issue of family, inside the family, because people were locked up and they had nothing to do, and relationships. So overall, generally, again, that also I like to mention quickly before I'll deal with it later on. Family relationships improved. You have better understanding, people were more accommodative, and they were able to appreciate each other. But in a certain minority, relationships became strained, and there was reports of increase in domestic violence and child abuse. Then alcohol and drugs. So one big development due to the pandemic was that access to many of the drugs, the hard drugs, they became unavailable due to all these lockdowns and travel restrictions and so on. So people started resorting to what was available, because to control their anxiety, or people who are already dependent or due to boredom, various reasons. So alcohol in various forms, particularly home brewing, became noticeable, and cannabis. So there's a change. But sometimes we had to face clinically people who went into acute withdrawal, and we had to treat them for severe withdrawal symptoms, particularly the people who had been addicted to the hard drugs. It's a big issue in Sri Lanka, and some violence and untoward consequences. So in mentioning, we always look at the negative side. There's another big complaint about our psychiatrists and medical profession, but there are also positive consequences. And there are a lot of lessons we can learn. Important thing is we don't need a pandemic to have these kind of positive effects, but it taught us that this can be done. So why can't we do it without having a pandemic? I mean, why can't we have these kind of approaches and so on? So overall, there was a better understanding of biological processes, about vaccines and viruses and these microparticles, and how people were getting infected. So why are we wearing masks and so on? And there was a better appreciation of ecology. Because one thing, the pandemic, there was a lot of improvement in the ecological situation. Pollution levels dropped, rivers became clean. So why can't we do this without a pandemic? Air was cleaner. So people were there, and then all these ecological movements also, although the pandemic may not be the direct cause, but it definitely gave a boost. New innovations and discoveries, and again we have to commend the laboratory technicians and workers who came up with so many vaccines very quickly, fast-tracked, and mRNA, using mRNA and so on, very commendable. And this can be now used for other type of conditions, and I think they are developing vaccines. Then the innovative ways of contact tracing, this QR and all kinds of things, improved ecology, I already mentioned, green social prescribing. So now in the planning, they are bringing green planning. So in a city, when they're rebuilding, you have green spaces and opportunities for people to be able to go and relax in environments instead of having a kind of a very bricks and steel environment. You can go and relax in a more natural setting. Online learning, another big boost. Everything was being done online. So education, lessons, discussions, seminars, conferences, all kinds of online innovations were done. There were a lot of improvements, and the studies even shown some students were doing better. But then, particularly the children and people, students who go to schools and classes, their relationships, their interactions were not there. So that caused problems, and there are the mental health consequences. Maybe I can come to that, but so they need that. So it's not just rote learning, but online was there was a big boost. And telehealth, there was a big innovation, and the government also chipped in, and there were a lot of incentives. And now I think it has become part and parcel of regular practice in online shopping and marketing and so on, social media interaction. So there was a big boost in the online sector. And there was a lot of gratitude showed to healthcare workers, more allocations for mental health. People were more appreciative, and even by online, they were coordinating some. In Italy, they banged their pants together. And I think medical profession itself became, the prestige rose very high. I think there were some surveys, and from pre-COVID times, the healthcare workers were appreciated. And overall, I would say, from what we could gather from the social media and from reports which we triangulated from what we were finding in the social media, the family and community cohesion increased. Although there were minority, there were problems and so on, but generally society came together. Families also came together. So they were facing a outside threat, and there was fear and anxiety and so on. And so the cohesion level increased, and for example, the suicide rate dropped in many countries. In some, there were some exceptions, but generally in Australia also the suicide rate dropped. So, so do we need a pandemic to have these things happening? Can't we get together without the pandemic? Then also there was a drop in various infections, respiratory infections, particularly the flu. The rates dropped dramatically. In Sri Lanka, we found dengue infections dropped. One of our colleagues in the paper has reported. But again, now there's spike. So do we need to all go around wearing masks and keep a social distance to control the flu? So it was called a social vaccine, these kind of measures. Suicide reduction in road traffic accidents, industrial and technological accidents, reduced inter and intrastate civil wars and conflict. Now all those things are back. Ukraine, and now we got the Palestine crisis. So during the pandemic, all these things went to the background, and we found that, and in fact, international cooperation, solidarity increased in getting the vaccine there, getting care there, and so can't we have this without the pandemic? So I think, Scott, I'm running out of time, so we'll go very quickly. So looking at it from an individual, family, and community point of view, COVID, people who had the COVID they have had a increased risk of mental health disorders. Some say up to 70%. So I have already mentioned most of this, so I don't need to go through again. But very important, and from a psychiatric point of view, this is the cohort that we will be dealing with. People with in fact, I have already mentioned many of these things. We can come back to any of these points in the discussion, I suppose. But it's very important to note that there was a very heavy toll on the individual level. And general measures that we could use, not only psychiatrists, for general practitioners and for healthcare workers, nurses and people working in healthcare, to encourage normal sleeping patterns, some physical activity, even though there are lockdowns and so on, to be able to do it at home. And this is available also online, connecting with people online if necessary by keeping in touch. So there are a lot of well-being resources available, and many of these, there were instructions and directions. I'll show you some of the pamphlets, WHO and so on. Even in Australia, quite a bit came out to improve mental health, improve and maintain well-being, and to provide psychoeducation support, reassurance is very important. Psychoeducation is a very powerful tool. In fact, lot of the main management is in explaining and reassuring. Then relaxation techniques, which I don't think I'll have much time to come to, but there are various techniques that can be used. Then treatment of disorders like anxiety, depression, substance abuse, these things had to be tackled, and use whatever is the guidelines provided. The college also has guidelines, but the GPs are now quite competent in managing. And in a pandemic situations, they were the front line, and they had to provide the care. But I think the Australian government also chipped in by providing a lot of support for the GPs. If necessary, then mental health professionals can be referred to. Then public awareness through various social media pamphlets. It is very important to use material that is understandable and culturally sensitive. So the big culturally and linguistically diverse population, CALD as they are called. In Victoria, there was an outbreak because the information was not provided in a culturally sensitive way. So it's very important to involve the community and the community leaders in getting this kind of information out. That's one of the big lessons of the pandemic. Then psychosocial determinants of mental health conditions, employment. A lot of people didn't have jobs. They lost their job, or they were not able to go for work regularly. They were to work from home. So these kind of issues. Then the pay, the economic impact. In fact, one of the reasons we found in Jaffna, from where I am, there was an increase in suicide rate, and that was due to the economical impact. That's what our analysis was. But many governments adapted, and they gave various loans, job keeping allowances, and leaves, and so on, and that carried. So you can see that the suicide rate actually in situations where the government provided this kind of support, suicide rate didn't go up. In fact, sometimes in many places it went down. Other is the housing. To provide housing, there are a lot of people who were homeless on the street, so they had to be found accommodation and so on. And that's a very important part, particularly looking after the elderly, the elderly, the old age care sector was really impacted, and elderly were vulnerable. Now, family was a particularly important unit for us to look at, because a lot of things were happening because of the lockdown and so on. So families faced losses, people died or they were affected by COVID, and then they had to be separated. Relationship was strained. So they're looking at the negative side. As I mentioned already, most families coped well and relationship improved. There was a lot of family activity. For the first time in their life, they were meeting each other for long periods. So they were better understanding, interaction. They played games together, and the children were at home. But unfortunately, there were domestic violence, child abuse, and socio-economic hardships, because not earning the same income, there were issues at home, and so we were encouraging home garden and so on, and to grow some of the things at home. So the vulnerable groups that I mentioned earlier, elderly were extremely badly affected, and they were the most vulnerable to catch the COVID also. And so we may need to think of better care methods for the elderly. Women, because they were the ones who were placed to run the home, look after the children. So a lot of the burden was on them. Then they had to face their husbands also, who were locked up in the house and were finding. So there was quite a big impact on women, youth, and children. So the big group who are usually naturally out there playing with others, able to sports and arts and going to school and meeting other friends, and so they had to stay at home, and they also they didn't understand what was going on. So big impact on youth and children. A lot of surveys done in all over the world. Here in Australia showed a high impact on mental health on children and youth. Disabled were badly affected. They were separated and they didn't have much support. There's another group, frontline health workers, already I mentioned. Some faced burnout. They worked extra hours. They really put their shoulder to it and worked. So they had to show better support and better understanding, recognition of what they did. But they also need support. So better to have these measures that we use available, and for them to meet or get the advice or guidelines or counseling or support they need when necessary. And there's a big stigma that is still there. There was a stigma about catching COVID and also the stigma of mental health. So this was something that works against people acknowledging and recognizing and getting help. Ethnic groups were unfortunately targeted. There were unfortunate stigmatization, social media, they were suspicion. They were saying certain ethnic groups were carrying the virus, or they were exposing themselves, or so this kind of dynamics targeted minority groups, and so they were at the receiving end of some of the more negative consequences. Really, the time up, is it? So
I've got about 10 minutes left.
Oh, okay. So that gives me a important because I much more at home with working with communities. That is my more area. So how do we? Of course, in Australia we look at a more individual perspective, but communities are also very important, and various reports and productions that came, publications that came out of various governments. The UK public health report, and here in the Australia also, National Mental Health Recovery Plan. They all as a priority, they all talk about a community-based approach. Of course, the individual care and the individual support and follow-up, all that is very important. I'm not saying that it's not important, but strengthen the community, make them resilient, make them able to manage and face some of these, so that many of the problems may not arise, all the anxiety and depression and difficulties that communities face. So we also saw some consequences at a community level, which is very interesting. The one that I already mentioned about the social vaccine, people are feeling, there were even protests, and very strong, violent protests even, about all these measures like masks and lockdowns, restrictions on traveling, and compulsory vaccination, anti-vax groups. They called it Nazi mechanisms that were being used. So it is better to market these things in a proper way that people understand and are able to accept. But there are some groups and people who take advantage of these kind of situations to produce unrest and get people agitated, upset, and protesting and becoming violent. So this is a kind of phenomena that's still going on. So it has got repercussions. Maybe people learned how this can be set up. One thing that I like to point out, which was very interesting, is what we might call a kind of a mass hysteria. This kind of environment of fear and uncertainty and foreboding about what's going to happen and panic. Suddenly we found this kind of mass behavior, collective behavior that spread. People behave like a herd, like a panic buying of toilet paper. So here in Australia, we found suddenly toilet paper was not available in the supermarkets and so on. And any mention of some kind of this thing, immediately first thing to go is the toilet papers. Of course, all the other essential food items what people thought were essential also then quickly became unavailable, and the supermarkets were really and then there were difficulties in transport and supply chains. But people hoarded. In India, they were hoarding oxygen cylinders and ventilators and so on. People develop virus phobias and these conspiracy theories, anon theories, and that the world is going to end, and or this is being something due to the 4G. All kinds of things came up, and all this spread on the. So the first time I saw, I don't know whether this has happened before, but mass hysteria spreading through the social media. Usually it's a direct contact and people talking to each other or through other media, but here this spread through the. So you could even saw international dimensions to some of this, and a lot of fake news. News that were really deliberately created. They used modern technology and so on to produce various videos and this thing. And now the AI phenomena is here where they are producing all kinds of material which are fake. So these just spread. We just send it on the social media and it gets forwarded, and then people come to believe some of these. And so it's another big phenomena, very interesting phenomena. You can learn from it and also see what the psychiatry behind it. Disinformation, misinformation. Right. So enabling local council, that's what I already mentioned, strengthening the local community to look after themselves and to develop their own resources. There are a lot of leaders and there are a lot of youth and people who are very willing to do public service. So they can be motivated and they can be stimulated to carry out their own and to help now, like people who are separated or lonely, who don't have access to food or the help they need, then there can be groups that can go and visit and provide. So this kind of arrangements can be done at a community level, and that can be that builds up the community spirit. Community public health education. So these are some of the information, health related information that came out. One important group that's in a way related to the WHO is the Interagency Standing Committee, IASC. They have done a lot of work even before pandemic, in conflict situations, in disasters, and they came out with publications for general psychosocial skills for children, stories. You can get a lot of information to children through stories, important messages. For youth and for the elderly who are again very vulnerable, so the special for elderly. And here in Australia, the children were badly affected. So there was a lot of work by the Australian Human Rights Group and the National Plan. And then the UK also, they came out with a plan for the recovery phase.
Daya, we've got, you're going to move into the relaxation. We've just got a couple of minutes left.
Okay.
Just
So I think I can skip the relaxation. I think most of you all know about relaxation, but just very simple, straightforward techniques because people were locked down or under stress, or even when they go back to work, but the people were feeling stress after a long time after lockdown, going into a new or a old environment, social environment, meeting people and so on, people find that kind of stressful. So certain methods. So the one that is scientifically used is the Jacobson's progressive muscular relaxation, but there are culturally acceptable ones. So depending on the culture and the background, you can quickly they can quickly learn very easily, and it's more acceptable and seems to work better. I have a lot of experience using this in different settings, as Scott mentioned, in different. So here in Adelaide, I've used it in the stars, particularly quite a lot of Islamic people from various countries of Afghanistan and so on. As an Islamic method, Tikir. And there's a Buddhist method, Pirit or chanting. Hindus have their japa and yoga methods. And the Catholic Christians have the rosaries, prayer beads. So these are very simple methods that can be used to bring an anxiety under control. These are different religious backgrounds. So they have a religious aim, but they reduce anxiety. A lot of research has shown they reduce anxiety levels, they reduce the blood pressure, they reduce the pulse rate, breathing becomes easier. So very effective. Okay, Scott, sorry.
No, that's okay, Dave. I guess, I mean, great presentation. Thank you. I mean, you've covered the whole experience of COVID very comprehensively. I'm just, so and probably what you guys were able to do in the paper, which I found very interesting, was sort of systematically analyze all the social media and the information at the time. I wonder if there were any, if you picked up strong patterns. I guess it's best for people to look at the paper to delve into that. But could you comment on any particular patterns you saw across the world in terms of cultural differences in response?
So overall, there was this kind of picture of anxiety, depression, and so on. But they have a definite cultural aspects. And so, for example, in the way that minorities were targeted and they were sometimes blamed for the COVID. Very interesting to see how the dynamics worked. For example, in Sri Lanka, they were saying that Muslims were in a way responsible. They were, across the social, and then they banned their type of burial, which was a big, very important for Muslims. So many of the countries, there was a cultural aspect to the response of way the country responded. Some of the practices also were useful in the management, as I mentioned earlier, and people found solace in addressing the COVID challenge through cultural practices, various religious rituals, and attending to religious ceremonies and so on. So those things can be encouraged within the what is safe, public health, because some of these religious ceremonies became super spreaders. People gathered together, and then during that period, COVID spread, and then right after, within a week or so, the whole it was like a sudden outbreak. So masks and social distancing, vaccination. Unfortunately, in some countries, we found some other religious, not all the religious sector, but some of the religious people involved were campaigning against some of these measures. Like, for example, vaccine. Some other people, preachers now in Africa, there was 1 or 2 cases. The preacher was preaching that they don't need to take vaccines, and so that led to vaccine hesitancy, and or that this is all a hoax. This is not really being caused by virus. This is some kind of conspiracy.
Brought out the best of us and the worst in us, depending on who you were on and what given site and get any given day.
Yeah, and there are a lot of people in the audience also who may be able to contribute some of these cultural aspects that you asked about, Scott.
Thanks, Dave. I guess we're running out of time. Does anyone have any questions to ask of Dave online or? Nothing coming forward. I just, I guess it's, I'd recommend highly for everyone to have a look at the paper, because it is a great integration, and I think the process of pulling that together, using social media in the way that they've done is very novel. Like, it's an umbrella review of all the information that was gathered around the time, and I think that's it's a really sort of amazing effort. So I congratulate the whole team on doing it. And I guess it's always a pleasure to catch up with you, Daya, and I thank you very much for your time and input today. And please keep the information coming. It's great to see what you're doing with yourself these days. Oh, sorry.
Yeah,
question there?
Thank you so much for a great presentation, Daya. I was interested. I was about to ask you a question on. So we're working with GBG, collaborating with the Global Burden of Disease, and we just wrote a paper, and it's just been accepted, on pre-COVID estimations of in the elderly population of burden of disease across in Australia. And this year we are about to write a paper on post-COVID estimates in the elderly population in Australia. So burden of disease, post-COVID estimates. And I was wondering whether you would be interested in collaborating on this project, because your clinical expertise will be really, really relevant in terms of understanding the changes from pre-COVID to post-COVID estimates of burden of disease in the elderly population. So I understand it might be a big discussion. So if you're happy to, to talk about it further, we can take it offline and just,
Yeah, that's good.
Okay.
That'd be great. It'd be
Cool.
great to collaborate.
Yeah, it's a nice project, and yeah, but we as scientists quite often lacking knowledge. I'm talking about myself here, clinical expertise and understanding of the numbers, what they might mean in actual real life setting, clinical settings. So your input and your colleagues' input would be greatly appreciated in this paper.
I think surely the paper that we've just been talking about is Day's paper would be in the citation list for that paper.
Oh yes,
Yeah.
oh yeah, absolutely. We'll be happy to cite it as well.
I must run, everybody. So I guess if there's no more questions, I'll close the meeting at that stage. But just thank you very much, Daya, for spending some time with us today and talking about your research. And it sounds like we look forward to a new project with you.
Yes, thank you very much, Scott, for giving this opportunity. I'm sort of retired and but not being mothballed, so gives me a chance to talk and discuss and share.
You've done too much work to be mothballed, Dave. Too good a resource, too valuable. Thanks, everybody. Have a great week, and we'll be in touch.
Okay.
Thank you.
See you.
Thanks. Bye.